Okay, this is the last section of Chapter 2. We're going to talk about clinical implications. Just in this section, we're talking about cells of the nervous system, so we're going to talk about 2 clinical syndromes that are affected by cells in the nervous system. In the last section, we talked a little bit about abnormal glial activity and neural damage with different diseases. So just like the rest of the body, when we get infection, disease, or injuries, the body produces inflammation to deal with it. The central nervous system also has its own neuroinflammation to respond to infection, disease, and injuries. So the beneficial effect is that it initiates the signals that call those microglia to clean up and remove debris, but it can also cause the death of neurons and oligodendrocytes and inhibition of neural regeneration. So there are some nerve growth factors that will stimulate neural regeneration, and when those are inhibited, it can make it hard to recover from some of these things. So like I said in the section of the glial cells, there has been a correlation noted between abnormal glial activity and neural damage in things like stroke and Alzheimer's and Parkinson's and MS. So there's such a thing as too much of a good thing. So a lot of the 2 diseases that we're going to talk about in this chapter are both demyelination diseases. In the peripheral nervous system, peripheral neuropathy is any pathologic change involving a peripheral nerve, so it's a pretty vague term. Often peripheral neuropathies involve destruction of the myelin sheath, especially in the largest, most myelinated sensory and motor fibers. So they result in disrupted proprioception and weakness. So you'll work with a lot of people in the clinic, even if this isn't the primary thing they came in for, they will come in with peripheral neuropathy in their feet, and they have trouble with balance. There's this interesting gait pattern that you'll see where someone actually has a foot slap because they're not getting the signals, the proprioceptive signals, back to their cerebellum, and they don't have that awareness of their limb position, and they also have weakness in the muscles, and so they can't control that eccentric dorsiflexion as they take a step, and you get that foot slap from that. So it can be a demyelination injury, and we will talk in the chapter specifically about the peripheral nervous system. We will talk about other different types of nerve damage, but that's certainly one of them. So Guillain-Barré Syndrome, it's an acute inflammatory demyelination of peripheral sensory and motor fibers. So it frequently occurs 2 to 3 weeks after a mild infection. In 2/3 of cases, it's an intestinal infection that activates the immune system, causing production of an antibody that mistakenly reacts to the myelin sheath and breaks it down. So it's an autoimmune disorder. We will find, as we go through this, a lot of neurological disorders are being found out to be autoimmune disorders. So our immune system protects us, but it can also damage us. So really interesting stuff. They're still not sure exactly which pathogen, or there are a couple that have been implicated, and which one causes Guillain-Barré. So there's the most prevalent theory right now is the molecular mimicry theory, where one of the pathogens out there looks like some of the proteins on the myelin sheath, and the antibodies that attack that pathogen also attack the myelin sheath. So people with Guillain-Barré, they may have difficulty with chewing, swallowing, speaking, facial expressions. They often have a lot of pain. They have a lot of times they'll report a deep aching pain or hypersensitivity to touch. They have a very rapid onset. that is followed by a plateau and then gradual recovery. The good thing about GBS is that recovery is usually complete. It takes a long time, but it is complete. The thing that you have to avoid, a very small percentage of people with GBS die because of respiratory complications. Weakness in their respiratory muscles in their diaphragm makes it so they can't breathe. So if you get treatment right away, a lot of people, they have that 2 to 3 days of what seems like the flu, and then they have weakness in their legs, and then they might actually need to be on a respirator for a week or so. So I've worked with several people with GBS in an outpatient setting, so by the time I get them, they have already recovered quite a lot, and they're often walking with a walker or possibly crutches or 2 canes. Both the people that I've worked the longest with, well, 3 people actually that I worked the longest with GBS were very active people before they had it, and they were really interested in getting back to being active, and they all have done that. And so it's a nice thing to work with because people do recover. So while they're in the acute stage, they might have plasmapheresis, which helps remove some of those antibodies from their system, and then they might also get IV immunoglobulin therapy. So the immunoglobulins are those antibodies. They are always getting PT and OT during the acute stage, and then they often continue with PT and OT through their recovery. And they tend to gain their function back proximally first and then distally last. And so the people with GBS that I've worked with, they start to get their strength back, and it's usually their feet and ankles that come back last. And it's really encouraging to work with them because they do get better, and we can really do a lot in PT to help them get better. So multiple sclerosis is also an autoimmune demyelinating illness, but the immune system produces antibodies that attack oligodendrocytes. So they're the myelinating cells in the central nervous system, and they produce plaques in the white matter of the CNS. So they're hugely varied signs and symptoms because it depends on which neurons are affected. So a lot of people, the signs and symptoms are listed here: weakness, lack of coordination, impaired vision, double vision, impaired sensation, slurred speech. Disruption of memory and emotions are possible, but they're not as common as the other symptoms. One of the things that people often tell me is their first sign were visual disturbances, double vision or impaired vision. I've heard several people say it felt like they were looking through a screen, which I thought was really interesting. But it's really kind of difficult to diagnose because MS usually starts with one sign like that, impaired vision or double vision or impaired sensation, and then it completely resolves before a diagnosis can be made. So unfortunately, it's also sort of become what I like to call a garbage can diagnosis for other things, other nervous system issues. The person goes in to get evaluated, the doctor does a few tests and can't figure out what it is, and so it says, oh well, you might have MS. And then it turns out to be something completely different. I actually worked with a woman several years ago who she got diagnosed with MS, and it turns out she had a brain tumor. She did not have MS. And she had to get hooked up with the right doctor, and they did computer-assisted surgery at Virginia Mason and removed her brain tumor, and she recovered from it. But she was lucky. I mean, it could have been a different story. So with MS, the onset is commonly between 20 and 40 years. Women are affected more frequently than men, although I've worked with plenty of men with MS. There are 4 different types that are named according to the disease progression. The most common is relapsing remitting, and you have an acute relapse where the symptoms get a lot worse, they require acute treatment, and then it remits and you get back to relatively normal. That can go on for years before it develops into secondary progressive, which is where it starts relapsing remitting, but then it starts to just, you get gradual decline over time, and that's why it's considered secondary progressive. One of the people that I've worked with for several years now is in the secondary progressive phase right now, and works so hard, such a great guy, and I just love working with people with MS. One of the neurologists here in Bellingham, she calls MS the nice people's disease because she says everybody that has MS is nice. I don't know if that's true, but I've certainly worked with a lot of nice people with MS. The third type is primary progressive, where they don't get that relapsing remitting pattern. It goes straight to progressing and degenerating pretty quickly. That is maybe about 5% of people. It's fairly uncommon. And then progressive relapsing, they decline a little bit, and then they have an acute relapse where they're declining a lot, and then they continue to decline a little bit, and then they have an acute relapse where they're declining a lot. That seems the worst to me, but you never get that remitting time when you're getting better. PT and OT can be really helpful for people with MS to help maintain or improve their physical function. We're often working with people to help figure out ways that energy conservation techniques, ways to avoid high temperatures. There are cooling vests people can wear, setting them up with an exercise program, setting them up with assistive devices if necessary, working on balance, and really trying to slow the disease progression. As there are lots of medications out there that can really, really improve MS, and there are some videos on the Canvas Classroom that will talk about, there's one talking about GBS, an interview with a guy who had GBS, and just a description of what MS is. There's also a chart comparing the two. And all of the diseases we'll look at will sort of have the same pattern. The pathology, the etiology, speed of onset, signs and symptoms, regions affected, prognosis, and the PT treatment. So with GBS and MS, the pathology for both of them is demyelination. Both of them are autoimmune. The etiology is autoimmune for both of them. The speed of onset is similar, or you can have acute, subacute, and chronic for both of those. The signs and symptoms are going to be different. You can read through those signs and symptoms. With GBS, it's the peripheral nervous system that's affected. With MS, it's the central nervous system. A lot of people with GBS get complete recovery. 25% require artificial ventilation. 3% mortality rate. Those are probably the people that required artificial ventilation and didn't get it. People with MS live a normal lifespan. The course of their disease can be extremely variable, and so a lot of times when you're working with someone with MS and PT, you are developing a long-term relationship with this person. They are going to continue to come back either to get their program adjusted, or maybe you help them problem solve around some things that are going on for them. With a lot of chronic neurological problems, you are developing a lifelong relationship with this person. So with PT treatment for both of those, it's a common theme that we're working on functional mobility for a lot of people, and with MS in particular, we want to maintain or improve function wherever we can. Okay, so that's the end of chapter 2.